Venous air embolism. V is the entrainment of air into the venous. Venous air embolism. V is the entrainment of air into the venous circulation, leading to systemic effects. The volume of air entrained to cause significant injury is unknown but estimated to be 3-5 ml/kg in adults. The greater the rate of entrainment, the smaller the lethal volume. V can occur whenever the operative site is higher than the right atrium. Its incidence is particularly high during craniotomy in the sitting position and when the surgeon is dissecting tissues that do not allow veins to collapse despite a negative pressure within them, e.g., the emissary veins in the posterior fossa. There are three main consequences of V. Pulmonary microvascular occlusion, Pulmonary microvascular occlusion, resulting in an aphysiological dead space, hypoxia and pulmonary edema. Air bolus, larger volume causing air bolus, larger volume. The entrainment of air into the venous circulation, leading to systemic effects. The volume of air entrained to cause significant injury is unknown but estimated to be 3-5 ml/kg in adults. The greater the rate of entrainment, the smaller the lethal volume. V can occur whenever the operative site is higher than the right atrium. Its incidence is particularly high during craniotomy in the sitting position and when the surgeon is dissecting tissues that do not allow veins to collapse despite a negative pressure within them, e.g., the emissary veins in the posterior fossa. There are three main consequences of V. Pulmonary microvascular occlusion, resulting in an aphysiological dead space, hypoxia and pulmonary edema. Air bolus, larger volume causing obstruction to RV ejection, leading to pulmonary arterial hypertension and RV failure. Paradoxical air embolism. See below. Signs of V depend on the rate and volume of air entrained and include decrease in ECO2, bronchoconstriction, hypoxia, arrhythmias, myocardial ischemia, hypotension and cardiac arrest. N20 does not increase the risk of V but may worsen its outcome. Detection of venous air embolism. ECO2 is generally the most useful monitor, as it is widely available and sensitive. Air embolism results in a sudden reduction in ECO2. Hyperventilation, low CO and other types of embolism will also result in ECO2 reduction. Doppler ultrasound uses ultra-high frequency sound waves to detect changes in blood flow velocity and density. It is the most sensitive non-invasive monitor. However, it is not quantitative and does not differentiate between a massive or a physiologically insignificant air embolism. TOE is the most sensitive and specific monitor, but is invasive and difficult to place, and needs expertise to interpret. However, it can detect as little as 0.02 ml/kg of air. PA catheters are invasive, but sensitive monitors for V. However, an increase in PAP is not specific for air and they are very rarely cited. The least sensitive monitor is a precordial or an esophageal stethoscope to detect the millwheel murmur. This is apparent only after massive V, which is usually clinically obvious. Prevention: avoid the sitting position, unless essential. Elevate the head only as much as necessary. Ensure adequate blood volume to maintain a positive CVP. Small amounts of PEEP may reduce the risk of air entrainment. Although controversial, medical anti-shock trousers may be used to increase VP and reduce hypotensive episodes in patients in the sitting position. Identify susceptible patients. If risk factors cannot be mitigated, treatment. Supportive. Inform the surgeon, who should flood the operative field with fluid. This stops further entrainment of air and allows the identification of open veins that can be cauterized or waxed if within bone. If possible, position the operative site below the level of the heart to increase VP. Stop N20 immediately if used, and increase the Phi02 to 1.0. Consider increasing PEEP. With patent foramen ovale, support the BP with fluid and vasopressors. Attempt to aspirate air from the CVP line. The tip should be placed close to the junction of the SVC and the right atrium, and ideally confirmed radiologically prior to surgery. If a large volume of air has been entrained and surgical conditions permit, turn the patient into the left lateral decubitus position to attempt to keep the air in the right atrium, or alternatively the Trendelenburg position. There is little evidence for this. Commence CPR, if necessary. This may break down a larger air bubble. A paradoxical air embolism. Air emboli may enter the systemic circulation through the Thebesian veins in the heart, the bronchial vessels or a patent foramen ovale. Such defects may be small. Small volumes of air in the systemic circulation can have disastrous consequences, resulting in temporary or permanent symptoms of CVE or ischemia of other organs. Intracardiac septal defects are an absolute contraindication to surgery in the sitting position. This should be screened preoperatively in high-risk cases. Summary: venous air embolism, sequelae of V, signs of V, detection of venous air embolism, prevention, treatment. Temperature control: core body temperature in an awake patient is tightly controlled between 36.7 degrees Celsius and 37x31 degrees Celsius. Deviation above or below these temperatures causes the hypothalamus to initiate behavioral and autonomic mechanisms to restore normothermia. This tight regulation is lost under GA and neuraxial anesthesia due to drug-induced vasodilation, abolition of behavioral responses to thermal discomfort, and resetting of the threshold temperatures in which autonomic responses are activated, resulting in a widened range. The anesthetized patient is prone to hypothermia defined as core body temperature 36 degrees Celsius. This typically occurs in a triphasic pattern. Phase 1, rapid loss of 71 degrees Celsius within the first 30–45 minutes of anesthesia due to heat redistribution from the core compartment to the peripheries. Phase 2, loss of 71 degrees Celsius over 2–3H from radiation, 40%, convection 30%, evaporation 25%, and conduction 5%. Phase 3, a plateau occurs when heat loss is finally matched by heat production as maximal vasoconstriction is activated. Hypothermia in the perioperative period is not benign. Adverse consequences include coagulopathy and an increased need for transfusion, increased risk of surgical site infection, increased rate of MACE, reduced rate of drug metabolism, e.g., prolonged NMB, and delayed emergence from anesthesia. Measures to reduce the risk of perioperative hypothermia include identifying high-risk patients, high ASA grade, low BMI, undergoing major surgery, and using a combined general neuraxial technique, and treating hypothermia before commencing anesthesia, monitoring core body temperature, distal esophagus, nasopharynx, tympanic membrane or bladder at 30-minute intervals, maintaining ambient temperature in pre-op areas and operating theaters. Pre-warming fluids to 37 degrees Celsius for IV administration or internal irrigation, and humidifying respiratory gases using an HME filter. Active cutaneous warming, most commonly achieved using a forced air device, which should be used for all procedures with anesthesia time, 30 minutes. Active internal warming techniques, such as CPB and peritoneal lavage, are invasive and therefore are not indicated for most routine operations. Clinical considerations for bispectral index, BIS calculation, e.g. data is processed through several steps to calculate a single number correlating with anesthesia depth. BIS value 65–85, sedation 40–65, general anesthesia. Limitations of BIS studies: initial studies were observational, underpowered, and not masked. Cost and effectiveness: monitor costs several $1,000s, single-use electrodes cost $10–15 per anesthetic. Some patients with awareness had BIS 65, questioning its value. Detecting awareness: postoperative questioning can identify potential awareness events. Ask patients to recall events before, during, and after anesthesia. Managing awareness: close follow-up and mental health expert involvement can prevent traumatic stress. Patients under regional anesthesia and propofol sedation may recall events and should be informed. BIS and outcomes: some studies suggest triple low BIS, blood pressure, and anesthetic concentration increases hospital stay and mortality, but others have found no association. Awareness: Julian Barker. You are called to see a patient on the surgical ward by the sister because a patient describes being aware during surgery. You did not anesthetize the patient. How do you deal with the situation? Inform the anesthetist involved and the head of the department. There may be a departmental policy or someone with a special interest in awareness. Interview the patient with a senior colleague. Ideally, the anesthetist involved should do this. Always have a witness present. Establish the events surrounding the time of alleged awareness by reviewing the anesthetic charts, discussing with the anesthetist involved and the patient. Establish whether it is true recall or dreaming. Recall may be further divided into explicit: patient can recall conversations which took place in theater, or implicit behavioral changes postoperatively due to intraoperative subconscious learning, establish whether the patient was in pain. This has implications for long-term psychological sequelae such as nightmares and flashbacks. If there was a clear lapse in the standard of anesthetic care, then honesty with an admission of fault and an apology is appropriate. Document all conversations and assessments in the case notes. Hospital management, including the legal department, may need to be informed in order that the events can be documented for future reference in case of legal action. Offer counseling for the patient. What do you tell the patient? It is important to acknowledge the patient's feelings and let them know you believe what they are saying. This helps with the well-recognized psychological sequelae following an episode of awareness. These include anxiety, insomnia, nightmares, depression, a morbid fear of hospitals and doctors, and a preoccupation with death. It is helpful to explain why awareness might have occurred through no particular fault but instead because of the need to minimize the doses of anesthetic agents given. If there is clear fault on the part of the anesthetist, then it may still be wise to admit it. Although this is an admission of negligence, some say it may help to reduce anxiety for future anesthetics if there was a definite reason for the awareness. In summary, a full explanation of the events and an apology are recommended. What is the legal situation regarding awareness? An anesthetist has a duty of care towards a patient. A patient who is going to have a general anesthetic expects to be asleep and unaware. To decide whether there is a breach in the duty of care, the Bolam test is applied. In the 1950s, Bolam's leg was broken during a course of ECT. Bolam's expert witnesses claimed that the omission of a muscle relaxant was negligent. The experts called by the hospital were of the opinion that muscle relaxants were not essential. The judge ruled that a doctor is not guilty of negligence if acting in accordance with a practice accepted as proper by a responsible body of medical opinion, even though a body of adverse opinion also exists amongst medical men. An anesthetist must therefore prove that the technique he used is one that is considered to be reasonable by his peers. This is done through review of the anesthetic records by expert witnesses. If there is evidence of a shortfall in the standard of anesthetic care, then the anesthetist is guilty of negligence. If the awareness can be clearly linked to the page 0 or anesthetic technique, causation, then compensation is payable. When is awareness most likely? At induction and intubation, on transfer from the anesthetic room to theater, during procedures involving the use of muscle relaxants, TIVA. During procedures where low concentrations of volatile are used deliberately, e.g., LSCS or hypotensive patient, at emergence. Awareness with explicit recall has a reported incidence of approximately 1/500 and is most common during obstetric GA, especially at intubation. Awareness with pain is far less common. What are the causes of awareness? Induction, low doses of drugs as above. Intubation, too early or delayed due to difficulty or waiting for relaxant to work. Transfer. Induction agent levels fall. Adequate partial pressure of volatile builds up. During surgery, equipment failure, e.g., breathing system leak, disconnection, vaporizer, malfunction or exhaustion, TIVA line tissued. How do you monitor depth of anesthesia? Simple clinical signs: MAC, isolated forearm technique, scale muscle activity, esophageal contractility, evoke potentials, amplitude, e.g., spectral edge, frequency, cerebral function monitor, bispectral index, heart rate variability, BP, HR, sweating, lacrimation, pupils, based on population studies, frontalis, lost with relaxants, depth of anesthesia related to frequency of contractions, visual, auditory, somatosensory, changes in latency and frequency when significant EEG activity is seen. Processed EEG makes interpretation easier. Fathom monitor, loss of respiratory sinus arrhythmia, clinical assessment of the stages of anesthesia. 1.2, respirations, regular, irregular, pupils, normal, dilated, disconjugate, constricted, muscle, tone, normal, increased, tense, eye reflexes, loss of eyelash, loss of eyelid, loss of, cornealer, loss of, pupillary light, stage 1, 2, plain, laryngeal pharyngeal reflexes, swallowing, highest risk of laryngospasm. 3, regular. 3, plain eye, plain, IV. 4, regular, hypoventilation, irregular, hyponia, apnea. 3, progressive dilation with increasing depth, dilated, fixed, increasingly, relaxed, loss of glottic reflex, loss of carinal reflex, flaccid, BIS 100, EEG signal, awake, memory intact, digitizing. 80, sedation, artifact filtering, fast Fourier transform, beta ratio. 60, general anesthesia, deep hypnosis, memory function lost, near suppression, increasing burst suppression, cortical silence. 40, suppression detection, BSR and quasi, BIS equals weighted sum of subparameters, bispectrum. 20, sync slow. 0. Aspiration under general anesthesia. Cyprian Mendonca, a 20-year-old patient undergoing a hemorrhoidectomy, has been anesthetized and has an LMA in place. He is positioned on the left lateral side for a caudal epidural. As you are about to perform the caudal epidural on the patient, you notice a copious volume of fluid in the LMA tube. What is the immediate management? Stop the procedure and keep the patient in the left lateral position. If possible, apply a head-down tilt. Administer 100% oxygen. Suction all the fluid through the LMA tube. If the laryngeal mask does not maintain the airway adequately, remove it and administer oxygen via a tight-fitting face mask. Further management depends on the degree of aspiration and whether or not the patient breathing spontaneously. If the patient is breathing spontaneously, apply cricoid pressure. Apply mask CPAP and consider deepening anesthesia. Avoid cricoid pressure if the patient actively vomiting, risk of esophageal rupture. Intubate the trachea with the aid of a muscle relaxant, and apply suction to the trachea. A bronchoscopy can be performed to visualize any signs of aspiration. If the regurgitation is minimal, the LMA is correctly placed, and the patient remains stable without desaturation. The tracheobronchial tree can be suctioned through the LMA using a fiber optic scope, provided that the airway reflexes are adequately obtunded. If the patient is apnoic, intubate immediately and commence ventilation. Treat as an inhaled foreign body by minimizing excessive positive pressure ventilation until the endotracheal tube, and the airway have been suctioned and all aspirates are clear. A bronchoscopy could be performed to look for signs of aspiration. How would you diagnose aspiration? Diagnosis by clinical examination, which may reveal any of the following. 100% is laryngospasm, airway obstruction, bronchospasm, wheeze, crackles, hypoventilation, dyspnea, apnea, desaturation, bradycardia, cardiac arrest. Monitoring: decreased oxygen saturation, decreased lung compliance, increased airway pressure, increased slope of the capnograph trace. Investigations: tracheal aspirate may be acidic. Negative finding does not exclude aspiration. Chest radiograph: diffuse infiltration, arterial blood gases, hypoxia, hypercarbia and acidosis. Bronchoscopy: visualization of aspiration fluid. What would be your subsequent management of this patient? Sedation, analgesia and intermittent positive pressure ventilation (PPV) via net. Suction of the airway, optimization of FiO2 possibly with positive and expiratory pressure, PEEP, bronchoscopy and bronchial lavage if necessary, emptying of the stomach with a large bore nasogastric tube before extubation. Monitoring respiratory function, chest X-ray looking for evidence of pulmonary edema, collapse or consolidation. Further management depends on the clinical picture and results from the investigations. If the SP02 is more than 95% on minimal oxygen and the chest X-ray is normal, the patient can be extubated and monitored for signs of respiratory complications. If the SpO2 remains at 95% and FiO2 is less than 0.5, heart rate 100/min, respiratory rate 20/min, and the patient remains apyrexal, the patient can be extubated and the oxygenation and atelectasis can be improved with CPAP and chest physiotherapy. If SpO2 remains 95% despite FiO2 being 0.5, there may be solid food material obstructing part of the bronchial tree. The patient should be transferred to the ICU post-operatively for ventilatory support. Extubation should take place in the left lateral position with a head-down tilt. Further management: repeat the chest X-ray and blood gases, sputum culture. Antibiotics are not routinely used. Explanation to patient and relatives: what is the role of steroids and antibiotics? Steroids may modify the inflammatory response early after aspiration but do not alter the outcome. They may potentially interfere with the normal immune response. Prophylactic antibiotics are not routinely indicated, but they may be required to treat subsequent secondary infections. What are the risk factors for aspiration? Patient factors: full stomach, fasting from food for less than 6 hours, intra-abdominal pathology, intestinal obstruction, inflammation, gastric paresis, drugs such as opiate analgesics, diabetes, uremia, infection and trauma, esophageal disease, symptomatic reflux and motility disorders, pregnancy, obesity, uncertainty about time of intake of food or drink. Anesthetic factors: insufficient depth of anesthesia with airway reflexes, such as coughing, hiccups, or laryngospasm, or gastrointestinal motor responses, such as gagging or recurrent swallowing, being evoked and causing regurgitation. Aspiration: during IPPV with a mask, anesthetic gases may pass into the stomach and may increase the risk of regurgitation. Surgical factors: upper gastrointestinal surgery, increased intra-abdominal pressure, e.g., laparoscopic surgery, aspiration during anesthesia. The LMA does not reliably protect the lungs from regurgitated stomach contents, although it may act as a barrier at the level of the upper esophageal sphincter if it is correctly positioned. The incidence of clinically detectable regurgitation with the LMA is approximately 0.1%. The incidence of aspiration is low, approximately 0.02%. which is similar to the incidence of aspiration with tracheal intubation in elective patients. The following are practical guidelines to minimize the risk of aspiration while using an LMA. Avoid use of an LMA in patients with an increased risk of aspiration. Ensure adequate anesthesia during insertion of the LMA and during surgery. Avoid lubrication of the anterior surface, excessive lubrication, or use of lubricants containing non-aqueous solvents. Avoid gastric distension during positive pressure ventilation. Minimize peak airway pressures. Avoid inadequate paralysis. Therapeutic strategies to prevent aspiration in patients with risk of aspiration. Ensure that the patient is adequately fasted. Measures to increase gastric pH. Measures to reduce the volume of gastric secretion. Application of cricoid pressure. Protection of the airway by a cuff net. Extubation in the lateral head-down position after suctioning the oropharynx. The respiratory damage following aspiration depends on the acidity and volume of gastric content. 30 ml 0.3 m sodium citrate given 15 to 20 minutes prior to induction of general anesthesia and H2 receptor antagonists, such as ranitidine 150 mg orally or 50 nmg intravenously, increase the pH of the gastric juice. Metoclopramide increases gastric motility and reduces the volume of gastric fluid. Key points: as soon as regurgitation is recognized, the airway should be thoroughly suctioned and 100% oxygen administered. Further management depends on the clinical condition of the patient as indicated by oxygen saturation and respiratory signs. Regurgitation and aspiration can be minimized by avoiding the use of an LMA in patients with an increased risk of aspiration. Intracranial pressure ICP Oxford and Julian. 1. Normal ICP. 5 -15 mmHg. 2. Compensatory mechanisms maintain ICP until overwhelmed. 3. ICP rises steeply with small increases in volume once mechanisms fail. 4. Slow-growing lesions, large volume before significant ICP rise. 5. Fast-growing lesions, small volume can cause significant ICP rise. What is normal intracranial pressure? Around 10 mmHg or less. Sustained pressure of 15 mmHg is termed. The contents of the cranium are not compressible. Any significant increase in the volume of brain tissue, blood or CSF within the cranium will lead to a rapid rise in intracranial pressure ICP. 1. Increased brain volume, cerebral edema, swelling. 2. Mass effect, space-occupying lesion, hematoma, tumor, abscess. 3. Increased CSF volume, hydrocephalus, meningeal inflammation. 4. Increased blood volume, A. Increased CBF, hypoxia, hypercapnia, B. Increased cerebral venous volume, increased thoracic pressure, venous obstruction, cerebral perfusion pressure. CPP. 1. CPP equals MAP ICP. 2. Autoregulation maintains constant CBF despite changes in MAP. Normal CPP equals 80-100 mmHg. Remember that adequate tissue perfusion is not just a function of CPP but depends on blood flow and oxygen content. Cerebral blood flow CBF. Autoregulation. 1. Maintain CBF 50 ml/100 g min, between MAP 60-150 mmHg. 2. Impaired and chronic hypertension, acidosis, hypoxia, hypercapnia, and head injury. Factors affecting CBF. 1. Metabolism, determined by brain demands. 2. CO2 tension, hypocapnia decreases CBF. 3. 0-2 tension, vasodilation occurs only at P02 is less than 7 kPa, 53 mmHg. 4. Temperature, decreased metabolism and CBF with hypothermia. 5. Viscosity, increased CBF with reduced viscosity HCT, 309%. 6. Anesthetic agents, how can you measure intracranial pressure clinically? There are 4 methods commonly used via the skull and a lumbar approach via a CSF catheter. 1. Epidural catheter, strain gauge transducer, a tip or fiber optically supplied light reflecting off a pressure-sensitive membrane. 2. Subdural bolt or catheter, prone to blocking and leak,